Hello everyone. I am Dr. Noel Nalin Kumar. I am a consultant pediatric orthopedic surgeon with the HOSMAT group of hospitals in Bangalore. Now, today I am here to discuss about some basic or very common problems in which we come across in day-to-day pediatric orthopedic practice. So I'm going to discuss two important and very commonly seen issues in children, that is intoeing gait, and another is a flat foot. Also, after that, I would be talking a little bit about vitamin D and bone health in children, which many parents are anxious about. Now, regarding intoeing gait is a fairly common condition where the child walks with both the toes pointing inwards. Now, normally the toes are either pointing straight or slightly outwards, which is a normal gait. But some children tend to walk with the front of the feet toes pointing inwards, and you might have observed it is a very common thing in children. Parents come to us worried if this is going to be a permanent problem or if it can be corrected soon. Now, what I would first tell is it's a very common and a very benign condition. It's a harmless condition which usually resolves with time. Now, the causes can be rotation of the lower limb, most commonly at the hip level, where we call it the femoral anteversion, where there is a slight internal rotation of the thigh bone at the hip level. It can also happen below the knee, wherein we call it the tibial torsion, or it can happen at the level of the foot, where the forefoot, the bones of the foot are slightly turned inwards. Now, all these conditions are very benign conditions. I mean to say that they do resolve with time. We examine, we make sure that we assess and determine where the problem is. And most of our job is to reassure the parents to wait and watch and observe. Most of these problems resolved by the time child is 4 to 6 years of age, sometimes up to 10 years. Now, when do you need to worry? In a child who is having an intoeing gait, we need to worry if there is a very delayed onset of walking. Normally, child starts walking by around 12 to 15 months. If the child takes much longer to start walking, more than 15 to 18 months typically, then we start to investigate. If there are other problems in the knees, like knock knees or bow legs, that means when you see the child standing, there is a deformity at the knee level. That means there might be a secondary problem which is causing the intoeing. And very uncommonly, we can also see slightly difference in length of both the legs. So if you do observe any of these issues, then we need to bring it to the doctor and get a formal assessment done. Another very common problem I face is a flat foot. Flat foot is one of the conditions where we see about two cases every week. Parents are anxious and they want it corrected as soon as possible. Now, one thing about flat foot is children develop arches over time. In almost all newborn babies, there is no arch. They usually have a pad of fat on the medial side, which obscures any arch which is present. Now, this arch gets prominent as the fat pad resolves. And the development of the arch might be delayed to up to as long as 7 to 8 years. So the first thing to note down is arch develops over time and we do not worry. And the most common type of flat foot is called a flexible flat foot. Flexible flat foot is one where the ligaments are lax. Ligaments don't have the required elasticity. Ligaments are the structures which join two bones together. Now, there are bones in the foot which are supposed to be aligned in a particular fashion, and the ligaments hold all of them in place, assisted by the muscles. Now, what happens because of this lax ligaments, when the child puts pressure on the foot, the ligaments are not able to hold the alignment of the bones together and the arch collapses. Now, collapse of the arch is one part of the problem. Along with it, what happens is the inner border of the foot gets elongated and the outer border of the foot gets compressed. This combined with the slight outward deviation of the heel and tight heel cord. Now, all these are seen together. A flexible flat foot is something which we need not worry because, like I said, it usually resolves by 7 to 8 years of age. And in those children whom it does not resolve, whom there is persistent flat foot even after the age of 8 to 10 years, most of them are asymptomatic. That means even though they have a flat foot, they don't have any issues in their routine day-to-day life, in sports activities, in running, in any of the activities. So, in technical terms, it is called a plano-valgus deformity of the foot. Like I said, valgus means the outward deviation of the front of the foot. Now, flat foot in itself is not a problem. Flat foot needs to be addressed only when it starts producing symptoms. So in children where it spontaneously gets better, there is no other treatment required. In children who have persistent flat foot, it doesn't make sense to give them an arch support or a modified footwear as a routine because the footwear is not going to change the shape of the foot no matter how long you wear it. In fact, it might be counterproductive to give a modified footwear in a child who is otherwise asymptomatic because many of these children do develop pain after wearing these modified footwear because it is need based. One is uh, the child does not feel the need to wear. It is like wearing a spectacle. If your eyesight is fine, it's very difficult to force somebody to wear a specs. So the same thing happens in the child. They feel the pain because they will not be consistent with the footwear, and anyways, it won't change the natural history of the problem. Now, when you should be worried about flat foot. So, children develop pain. Usually, it starts around 8 to 9 years of age. If the pain is significant enough for it to disrupt normal day-to-day activities of a child or prevent the child from sporting activities, then that is the time we should start assessing and intervening. Or if the deformity is progressively worsening, some children start walking, the weight bearing is on the medial border of the foot, and visually the deformity looks quite bad, which might impair even the normal footwear. They have difficulty in wearing normal footwear. That is the time when we need to intervene and make the foot better. Another thing is advice for the parents is never stop the children from participating in sports or running or any other activity because they have flat foot. Because like I said, asymptomatic flat foot should not normally interfere with any activities, including professional level sports. In fact, many professional level sports persons have flat foot and it has not impaired their progress in any way. Now, when we do treat, the treatment is usually some stretching exercises combined with arch support. Again, should be noted only in the child who has symptoms, not in a routine, uh, as a routine. And very, very few require surgery as a last resort where nothing else is working. Uh, Flat foot is very, very prevalent among general population. In adults, it's about 20%. That means every 1 in 5 adults have flat foot, and most of them can lead a normal life without any issues. Now, few minutes I would like to take to discuss about vitamin D and bone health in children. This is something which parents and to strengthen the bones, and how much vitamin D is important. Now, a word of vitamin D. Unfortunately, we see a lot of vitamin D deficiency in India, though we are a country where enough sunlight is there. But when adults don't get sunlight, we tend and do a lot of indoor activities and avoid sunlight. And that is probably the reason where we are seeing a lot of vitamin D deficiency. Now, vitamin D deficiency, severe and chronic vitamin D deficiency in children causes a condition known as rickets, where the bones become soft and they start bending. The condition in adults is called osteomalacia. Now, that is one finding. The other things is a lot of muscle aches and muscle tone reduction is seen in children and adults who have vitamin D deficiency. Now, how is vitamin D helpful in bone? So, vitamin D is a vitamin which helps in absorption of calcium from the intestine, and also helps in mineralization of the bone. So having a normal vitamin D is extremely important to maintain calcium levels in our body and also mineralize the bone. Recently, it has been also implicated in a lot of other important physiological functions, including heart health, neuro health, and development of the baby inside the uterus. So, and how to make sure you have enough vitamin D. Now, vitamin D, to have enough vitamin D, we need adequate sunlight exposure. The dietary sources of vitamin D are very few. Uh, Enough vitamin D is only seen in some oily fishes. Otherwise, most of the dietary sources of vitamin D have very less amount of vitamin D, and even fortified foods don't have enough vitamin D. Now, sunlight exposure anywhere between 10 a.m. to 3 p.m. is the best time to get exposed without any sunscreen for adequate vitamin D production. Sunlight exposure, full body sunlight exposure enough to cause slight uh, dark individuals. This time exposure more because they produce slowly, and also with age the same amount of sunlight exposures tend to produce less vitamin D. So every day is supposed to help with enough vitamin D in the body. Now, when the ultraviolet rays falls on the skin, there is a compound called as 7-dehydrocholesterol in the skin, which gets converted into a pre-vitamin D3. This pre-vitamin D3 is again hydroxylized in liver and then kidney to become the active form. So when there is a vitamin D deficiency, like I said, the absorption of calcium from the gut is reduced. Now, what happens when the absorption of gut calcium is reduced? The blood level of calcium comes down. But the body needs calcium not only for bone health, for various physiological functions, including muscle contraction and so on. So the body needs to maintain adequate calcium levels in the blood. So what happens is because of the low calcium, hormone called parathyroid hormone is uh, the excretion of parathyroid hormone is stimulated. Now, this parathyroid hormone, what it does is to maintain adequate calcium levels in the blood. To maintain calcium levels in the blood, it is not getting from the gut, so it extracts it from the bones. This is how the bone strength starts decreasing. So, chronic vitamin D deficiency causes resorption of calcium from the bones to maintain adequate blood levels of uh, vitamin D. Now, this is probably the reason when we do a test for vitamin D and calcium, we see that there will be low vitamin D, but almost always you see that the calcium levels will be normal. Now, this is the reason why calcium levels are normal. the net calcium level in the body is still less, but the blood levels of calcium are maintained. So this is also the reason we give calcium supplements along with vitamin D supplements, because we know that the absorption of calcium is going to increase from the gut. So that is the reason we need a calcium supplement along with a vitamin D supplement. So like I mentioned earlier, natural vitamin D is got from the sunlight. Artificial vitamin D is from supplements. The natural vitamin D is much more effective because it has a longer half-life, stays in the body much longer than what the artificial vitamin D or the supplements vitamin D stays in our body. So, and bone strength. See, vitamin D, phosphorus, calcium are the building blocks that are necessary to keep the bone strong. But that is not the end of it. Now, it is like to build a building or a wall, we need a brick and cement. But brick and cement in itself is not enough to build a wall. We need to do a hard work of arranging those in a particular way to get the wall done. It's the same way. When parents ask me about bone strength, being a strong kid and strong bones, it is important that not only we provide the raw materials for the building blocks for a strong bones, but also the necessary stimulus for the bone to be strong. The body, our body is very smart and intelligent. It assesses what is our needs and adjusts accordingly. So if if the child is active in sports, is exercising, that is the stimulus for the bone to become stronger. Now, why is it important? Uh, it is not only important to have strong bones for the short term, but in the long run, a healthy, strong bone in young age determines how your bones are and how strong your bones are when you're old. Because there's a concept called peak bone mass. Peak bone mass is seen at the age of around 30 years. Now, that means at around 30 years, you have the strongest bones. After 30, the fourth decade, we start losing bone strength. The net production is much less than the net loss. So we gradually start losing bone after the age of 30, which accelerates uh, as we grow old. So if our peak bone mass is less, our chances of osteoporosis and their problems become much more at a much younger age. And to make sure that we have the very good peak bone mass, it is important that we not only give the building blocks, but also give the essential stimulus. So that is why enough physical activity, enough sporting activity, exercise, weight training, and resistance training is extremely important even in children. So those are broadly the topics I wanted to cover, and a small word about uh, differences in pediatric ortho and adult orthopedics. See, children are not just mini version of adults. There are orthopedic problems very unique and only seen in children, like hip dislocation at around the time of birth or after birth, cerebral palsy and the changing presentations, something called as Perthes disease, where the blood supply of the head of the femur becomes less, some condition called as slipped femoral epiphysis, where the growing physis, the growing part of the bone slips and becomes goes into a wrong position. So these are, and also the way we treat fractures in children is much different from how we deal with adults, because uh, children bones are growing, they are growing in size, length, girth. So what happens is they have a fantastic ability to remodel. So a lot of fractures in children are treated non-operatively. Of course, there are different parameters to guide us when we need to intervene, at what age, and how. So, in that sense, pediatric orthopedics is a completely different and unique field. With that, I would like to end my talk and take a few questions. What causes valgum in children? How is it treated when it get normal in children? So, valgum, also called as knock knees, can be seen in children. There are a lot of causes for it, and one of the causes is weak bones. In rickets, most commonly we see bow legs, but there are other kind of metabolic issues where knock knees are quite common. Now, knock the treatment is twofold. One is to address the basic problem, the metabolic problem, which is causing softening of the bones and bending of the bones. That is the first thing. And depending on the severity, we need to correct the alignment. Like I said, if we correct the basic underlying metabolic issues, the deformities tend to get better with age as they grow in height. So a smaller kid with knock knees has a better chance of getting better without any active intervention, without any without with just the taking care of the metabolic issues. Again, it also depends on how severe it is to begin with. In case where we need to do some intervention, we have very minimal interventions because the child's bones are growing. We need not do a surgery where we cut and realign them. Instead, we do something called as a growth modulation. Growth modulation is a minimal invasive surgery where we redirect the growth of the bone in the desired direction. So that is how we approach knock knees or bow legs. The second question is, if there is pus in the leg bone and we get it operated on, is there a possibility of any problem in the future? Now, infections in the bone, and specifically infection of bone in children, are a very major problem and an important issue. Infections in bone tend to stay on for longer periods of time, and they are very stubborn. Most of the times we need surgical intervention to clear the infections from the bone and adequate cover of correct antibiotics. So this eliminates the chance of it coming. I should not say eliminate, reduces the chance of it recurring in the future. But there is a small possibility, because of various reasons, because of decreased immunity, because of uh, if the bacteria is very virulent, there is a small possibility that the infection might come back again. But in most children where the surgical treatment is complete removal of the pus and adequate antibiotic cover, there should not be any problem. My twin baby having problem in walking. Her left side leg finger is a little bit large. Now, yes, now this problem appears like an isolated toe or a digit is bigger. It is a very uncommon condition and can be treated. It needs to be assessed. It macrodactyly, it's called a single digit, which is larger. There are a lot of reasons. There's a lot of fat pad accumulation along with the rapid growth of the bone. Now it needs to be assessed and intervened at a right level, and it definitely can be treated. Flat feet in kids and cures, and kids sitting in W position. Now, I discussed about flat feet. Like I said earlier, I'll repeat, flat feet in kids is something which you should not be worried about. The only reason to worry is when the child starts having pain, he doesn't go for his sports, or he refuses to walk for long distances because of pain in the foot, or if the deformity is visibly very severe, that is the time when we start worrying about the foot, about correcting, about treatment. If the child does not have any of these problems, then it can be just left alone, and the child can participate in all activities, including sports. Kids sitting in W position, like I mentioned earlier about intoeing gait. Intoeing gait is seen because of the excess anteversion of the femur, the hip bone. And these kids tend to sit in W position. Sitting in W position itself is not a problem, but the remodeling, the rate at which it gets better is slows down slightly. So I would not encourage kids sitting in W position. So you encourage them to sit in normal position, like we sit for foot on the ground. So that should be encouraged, and W position should be discouraged. What is the correct amount of vitamin D3, calcium, and vitamin K2, MK7 that can be given to children below 10 years on a daily basis? Yes, I'm glad this question came up. Now, ideally, we need not supplement anything in any child. No vitamins, no vitamin D, nothing. If we are suspecting that the child might be having a vitamin D deficiency, then first we need to determine how low is it and treatment accordingly. Blanket giving vitamin D on a daily basis does not make sense, and it is not necessary. Like I said, natural vitamin D is better in terms of longevity and the effectiveness. So try to get more of sunlight exposure. If you want to know if your child is deficient, then please get a test done, and accordingly it can be supplemented. The normal requirement in a child is around 600 to 1000 international units on a daily basis. In a child less than 1 year is around 400, and in an adult the normal daily requirement is around 2000 international units. But like I stated earlier, please don't give these supplements as a routine unless there's a documented deficiency of vitamin. Child seems to be healthy and proper weight. So how to identify bone deficiency? Uh, like I said, if the child is healthy, active, has enough, is taking home food which is nutritious and not taking a lot of junk, and is playing out in the sun and active, we don't have to do any preventive testing or blood test in a child who is otherwise normal and is healthy. So don't do anything. The next question is, my child is 2.5 years old. She has speech challenges. Could ortho problems lead to speech and autism issues? So the one condition which we see both speech issues and orthopedic problems is probably a condition like a cerebral palsy, where in a very young child or at the time of birth, the brain is affected because of lack of oxygen in some way. And depending on severity, it affects musculoskeletal issue, the muscles, and also it might have weakness on other areas like hearing, speech, the eyes, squint. So if it is related to cerebral palsy, definitely we can do an orthopedic assessment. But orthopedic problems don't cause speech impairment or speech challenges. They are both separate issues. The next question is, got sprain in back. Observe pain for a few seconds while leaving bed and getting up. No problem in walking, etc. So if it's just a back pain which is there for a few days and it's just momentary, then probably don't have to worry. And it's not specified if it's a child or an adult. If it's an adult, we need to just do some back strengthening exercises. Unless the pain is severe or radiating down the legs, we don't have to worry about this pain. If it pain persists for more than a month, then it's better to consult an orthopedic surgeon. Spine curve can be resolved. Yeah, spine curve. The normal curves like lordosis of the lumbar spine are the normal curves. The abnormal curves is scoliosis. Why? What we call as scoliosis or hyposcoliosis. That means if you observe the spine from the back, it should appear straight. If there are any curvatures, when we observe from the back, it is deviating to the right or left, which is an abnormal curve. A small deviation is acceptable, and it also depends on the age of the child. Deviation in a very young child needs to be observed for any worsening and has to be treated accordingly. If you observe that any child is having a spine curvature, definitely needs to be addressed, documented, and monitored for any worsening. The next question: how much time does it take for tibia fracture plaster removal? So again, the fracture healing in children is much faster as compared to that of adults. In children, we keep the plaster anywhere between 4 to 6 weeks. Adults who don't get operated and the fracture is treated in cast might require up to 2 to 3 months in a plaster. I don't think there are any more questions. Thank you very much.